Hello, my name is Michael Kutcher. I'm the Director of Interventional Cardiology at Wake Forest University School of Medicine in Winston-Salem. I'd like to introduce my colleague, Hank Jennings.
Hank Jennings here. Been in the society for a long time and have been in practice at St. Thomas for a long time here in Nashville and most recently at Vanderbilt.
Tip of the month is going to be a succinct paragraph about a particular problem and some solutions, a direction to a focused slide set, and interaction with other colleagues out there. What we wanted was a daily practice where you're talking with your colleagues and saying, I got a problem here. Hank, can you help me out? This happened. And in today's world, some of the problems are not so much technical as they are dealing with case selection and appropriate use.
So Mike, this first month's tip, we wanted to focus on the most common inappropriate use indications or case scenarios as reported by the SCAI-QIT PCI registry. And the one that's easy to deal with is the acute coronary syndrome ST elevation infarction one. There's one big one that falls out, and it's the stable patient who's greater than 12 hours out from presentation. You're really not supposed to do anything there. More problematic, I think, are the decisions that have to do with the non-acute coronary syndrome patients that represent the majority of the patients that we deal with. You want to speak, Mike, to the big ones that sort of stare out at you from the data?
Absolutely. Non-acute coronary syndrome patients are a particular problem because a lot of our institutions, ours in particular, don't have that many of them. We have unstable patients. But if a patient's stable, it's been found that there are a number of issues that are deemed to be inappropriate. One is if it's one or two vessel disease without involvement of left anterior descending. The patient is asymptomatic or very mild symptoms. They either have not had an exercise test or the exercise test is very low risk. They're not on two different anti-anginal agents. When the NCDR looked at this, these were the most common inappropriate cases. And in the AUC criteria, it's case 12, 13, and 14 that basically involve this summary that I just indicated.
One of the things that we've found here, Mike, is that having the big charts posted in the cath labs with all the various I's and U's and A's and so forth has been helpful, but it was a little cumbersome to use. And I would like to put in a specific plug for Kaylin Ho's great online application that has now been rolled out by SCAI and by the quality committee. It's one that's handy, it's easy to use, and it's a significant improvement over the laminated chart in every cath lab. We really want to hear from people, not only our SCAI quality champions, but all of the folks, members and fellows that are in the society, with ideas about how we can improve on this, specific ideas about topics to cover and to address. Would like to hear from you.